Most cardiovascular disease could be detected much earlier with a simple, non-invasive and once-off calcification test. The test produces a score running from 0 into the thousands, and that score correlates with the amount of heart disease in your arteries. And when it's discovered, heart disease can be treated and managed, just like we do with any other disease. But cardiovascular disease isn't just any other disease. It is the world's biggest killer, claiming more lives than all cancers combined and the lives of 7 times more than breast cancer. In cardiology, it seems it has to be a crisis before it's a problem. Many preventive cardiologists argue for a mindset shift when it comes to heart disease. Their passion is not based on gut, nor a hunch, nor intuition. It is based on evidence. In fact, an expert review on coronary calcium in 2008 concluded that overall, coronary artery calcium is a better predictor of events than all the other risk factors combined, since it measures actual disease. The review confirms that traditional Framingham score risk assessment still fails to identify many asymptomatic patients, until it's too late. The American Heart Journal published a study of over 136,000 people presenting at 451 hospitals after heart attacks. The study revealed that half of them had normal LDL cholesterol. And even for those that are identified, exercise stress tests or angiograms in asymptomatic patients may miss many of the most vulnerable cases because the artery blockages that the tests seek are not the cause of the majority of heart attacks or sudden deaths. 70% of heart attacks are instead caused by the sudden rupture of soft plaque. That's why so many asymptomatic patients go straight from just fine to dead. The real value of the calcification test is that it allows us to accurately detect whether or not there's actual disease in individual patients. Patients that might otherwise be inappropriately classified as middle risk by the Framingham population approach. And middle risk is where most heart attacks occur. People with high coronary artery calcium scores are immediately reclassified as high-risk patients. They learn that they have a time bomb ticking in their chest. More than 20 major studies over 25 years have all added to the momentum behind calcium scanning as a strong predictor of future cardiac events. Together, they have accumulated irrefutable evidence that a high calcium score is bad news.
We've been inferior doctors in cardiology for quite a long time. We've been waiting for heart attacks, we've been waiting for chest pain, we've been waiting for patients literally to suffer sudden death to jump in there with guns blazing and catheters interacting and trying to save them rather than getting to them earlier before the first event. I think we're really falling short on our oaths to improve heart disease care.
The world continues to accept the scourge of cardiovascular death like an inevitable event, a deadly lottery. For 1/3 of its victims, their first symptoms are their last. Many ate well, didn't smoke, didn't drink to excess, and watched their weight. All great things to do, but as individuals, they did not know they had heart disease. But the hard facts about heart attacks show that you can, anyone can, dramatically improve the odds. Now that's what I call a happy ending.